Premenstrual disorders are part of a spectrum that ranges from 0 to extreme mood swings and ideas of suicide. So about 40% of women will experience premenstrual syndrome. They feel irritable before their period, and probably about 5% of women experience much more extreme symptoms. So there is no test for this condition, unfortunately. It's linked to the normal menstrual cycle, but some women are extremely sensitive to the hormone progesterone that's released after ovulation. So symptoms start around the time of ovulation and they're relieved by the period coming. And the only real cure for this condition is the menopause. So that's one good thing to come from the menopause. It's really important, if you think you might be suffering from PMDD, to have a proper diagnosis. And this should be based on recording how you feel over a 2-month period. This has been recommended by the Royal College of Obstetricians and Gynecologists. And one of the reasons for this is to make sure that if you are going to have extreme management, which might involve surgery, and that's the kind of end of the road management, that's offered based on a really robust diagnosis. And any woman who is so severely affected that she's considering having her ovaries and uterus removed should have a test run of something called a GnRH analog, which is injected, and it's best injected for 12 weeks at a time to avoid what we call an agonist flare. So I kind of hope I've explained that this is a spectrum of conditions. The diagnosis is important, and because the hormonal changes are normal, there's no test, and the really important thing is the impact that your symptoms have on you, but also those round about you. So there are no licensed treatments in this country which work, but there are treatments available, and it's really important that you know that, because you may currently be feeling absolutely desperate. And I think one of the things which happens to women who have PMDD is they feel horrendous, they lose motivation, their mood is low, they're irritable. They may have physical symptoms as well, although most are psychological, but they might have abdominal swelling, breast tenderness, headaches, lethargy. So you can imagine that all these things mean that you can't conduct a normal quality of life. But it's important to know that there are things which might make you feel better. Simple things that your GP may be able to support you with, or your healthcare professional. It could be a practice nurse, it could be a pharmacist, talking about diet, exercise, cognitive behavioral therapy. For some women, going on to a pill with a specific combination of hormones can prevent ovulation, which, as I've said, is the cause. But we have to be careful with contraception, because not only are affected women sensitive to their own progesterone, they can be sensitive to synthetic hormones known as progestogens. So the other thing which we can deliver in a primary care setting are drugs which affect how sensitive the brain is to those hormonal changes. And we know that serotonin is very important, and drugs known as SSRIs will affect levels of that neurotransmitter in your brain. So for some women, taking what we would commonly use as an antidepressant can make a huge difference, up to 80% relief in the symptoms experienced. And it works very differently in PMDD. So instead of it taking weeks and sometimes months to kick in, the effect is pretty much instantaneous. And some women will use drugs like that from the point of ovulation, from the time that they feel symptomatic until their period comes. So they're not taking medication all month long. There are other treatments, but those are the main things. If those have failed, then you would expect to be referred on to a specialist provider, ideally a multidisciplinary team, which in an ideal world would include a gynecological endocrinologist and a psychiatrist, perhaps a psychologist and a dietitian, to ensure that women are offered the best quality care. I'm not sure that that happens in very many places in the country, and there are very few gynecologists with a special interest. But one thing which can occur in patients, in women affected by PMDD, is if they use an app, Prementrix is an app which I would recommend, then they can send the graphs which cover a whole range of different symptoms to somebody who does specialise in the condition, and it can be managed remotely. So women who are referred on to specialist services would normally be considering these GnRH analogues, which basically induce a kind of chemical menopause, if you like. That shuts everything down, so there is no hormone cycle any longer. So any of the symptoms associated with PMDD will go, but unfortunately, menopausal symptoms will kick in. And it's important for these women that they are provided with add-back hormones, so estrogen to make them feel better, and if at all possible, a progestogen, if it can be tolerated, to protect the lining of the womb. Some women who have PMDD are sensitive to all sex steroid hormones. That's very extreme, but it's important to identify these women because they may find it difficult even to tolerate estrogen, and that has implications if you're considering shutting down the system and giving add-back hormones. So this should be done in a logical manner, and Prementrix, the app which I mentioned, will allow you to record menopausal symptoms in association with use of a GnRH analogue, and it's therefore really helpful to your physician to allow them to understand the best way of managing your condition. Under no circumstances should women have their ovaries removed without the uterus, because in that situation, the endometrium still has to be protected with that more difficult class of hormones. So I hope I've given you some hope if you're a sufferer, that there are things that we can do to help and support you. I also hope I've made it really clear that this is a cyclical condition. It's linked to ovulation, and the symptoms go away when menstruation starts. If that's not happening to you, then you may not be suffering from PMDD and you may have another condition. The World Health Organization last year recognized PMDD as a condition, and I think that's helpful because it raises awareness. The BBC this week are focusing on PMDD, and it's very much been swept under the carpet, and that's because it's part of a spectrum. It's also a very difficult condition to diagnose and manage, and therefore for some people, for some clinicians, it's easier to pretend that the condition doesn't exist, to dumb down those more extreme end of the spectrum symptoms and say this is a normal phenomenon that happens to all women. But it certainly doesn't. Not all women feel suicidal at the time of ovulation up until they start to bleed. That has a huge impact on well-being. There are research projects ongoing trying to look at drugs that can be licensed to manage this condition. So I hope this podcast has given you some food for thought. I think there's a lot of unknown, a lot of questions unanswered, but raising awareness is always going to improve patient care in difficult conditions.